During the MDGs era, a lot of emphasis was placed on innovative financing, and there are a lot of different ways innovative financing is defined, but very often it ended up being taxes. And I'm not completely sure that taxes are so innovative. Certainly what was innovative in the MDGs eras were global taxes, such as the tax on airlines, the unit aid tax. And then there were some financial products that also were developed. But what is clear is none of them has really the potential to provide significant amounts of money in a way that what is required for universal health coverage. During the MDGs eras, while we were having that conversation about innovative financing, in fact, most countries in the developing world did not increase significantly the share of public taxes and public finance going to health. That really brings us back to that message of UHC is political, because who decides about allocations is taxpayers and parliaments. And obviously that priority given to health has not taken place in many countries, particularly developing countries. If we want an efficient system that provides services to the poorest and to the most disadvantaged, then public financing is essential. Because it is about redistribution, it's about solidarity, it's about healthy people paying for the sick. That's the insurance part. And it's about rich people paying for poor people. That's the welfare state part. It's about the social contract. So the public purse is essential. And I think we really have come to the conclusion that in any case there will always be private spending on health. People do spend on health. Families want to spend on health, and it's a good thing. But if we really want to have a full protection from catastrophic illnesses, if we really want to have a full access, we need a very fair amount of public money, of collective financing going to health for that cross-subsidization between sick and between healthy and sick, and between poor and rich. Our research shows that even in the low-income countries and in the fragile states, external funding doesn't represent more than 25% of total funding. Most of the funding is domestic. The problem is it's not always public. It's been out of pocket. It's actually people paying, including poor people paying, or and paying for sometimes not optimal quality health care. Between the availability of funding that the economy of a country could sustain and the policy that will lead to that funding to be pooled into a collective mechanism through taxation, there is a space for policy and politics.